Assalamu alaikum. Good afternoon. Thank you for the nice introduction. And I think I'm just going to start with the previous speakers. They really mentioned a couple of things is very important in my presentation. One of them that we have to really act early before the patient go into CKD in our diabetic patient. And the other one also to look at the whole patients, not to only one lab or one issue. So today I will talk about one of the newest option of treatment for our diabetic patient with CKD. So hopefully we will try to apply it in our practice I think for the last decade now. Since 2016, we're having more options and more treatment really helping our diabetic patient in reducing renal complication, cardiorenal and cardiovascular disease, started with GLP-1, SGLT2, and now we have another option to offer our patients. So we know CKD in type 2 diabetes is very significant. We have in 2019 about 160 million patients with CKD and type 2. And unfortunately, as in the definition, it's a chronic disease, and it's usually asymptomatic at the beginning. So this is where, as internists, family practitioners, GPs, and so on, where we have to really act before they get worse. So you can see it's about 2 out of 5 patients who will have some kind of CKD in different stages. And we know it's very important because CKD in type 2 diabetes increase the risk of mortality. So you can see if somebody, diabetic patient, develop any kind of CKD, they have 6 higher risk of dying and mortality comparing with no type 2 diabetes or CKD. And it's really progressive disease, and the risk of cardiovascular disease increase depending on the progression of the disease. So you can see if we look at the urine albumin creatinine ratio, starting at 10 milligram per gram, we start seeing the increase in cardiovascular mortality. And it continuously goes up. And also for GFR, which comes a little bit later after the microalbuminuria or albuminuria, again, we can start seeing the increase in cardiovascular disease after decline from lower than 65 GFR. So we talked about the importance of it because really it shortened our diabetic patient about 16 years comparing with a patient without diabetes and CKD. And despite all the guidelines, ADA, ACE, or all the guidelines, despite their recommendation to screen our diabetic patient early on annual basis with GFR and urine albumin creatinine clearance, you can see even in the developed country, the percentage of or compliance with this recommendation is really low. It varies from 20%, 29% in France, up to 66% in UK. So our job as internists, family practitioner, and so on, to really apply those guidelines to detect as early, because as we said, usually CKD, initially it's a silent and in a way it's a asymptomatic and silent progression which can kill the patient down the road with morbidity and mortality. So we can really detect it early by doing the eGFR, which index of kidney function, and we can do the urine albumin and creatinine clearance, which is also marker of kidney damage and early fibrosis. So the definition of CKD, as you see here, GFR less than 60 or urine albumin creatinine ratio more than 30 milligram per gram, which persists more than 3 months. So any patient, at least we need to do screen once a year, but the minute we have a patient with CKD, we need to start doing it more at least twice or 3 times, depending on the level of albuminuria and the GFR reduction. So the next few slides, we really need to emphasize on the inflammation and fibrosis as one of the key drivers for CKD progression. So we all know about the hemodynamic and the metabolic driver for CKD, but most of the time we forget about the inflammation and fibrosis, which affect our tubular interstitial cause damage, inflammation, glomerular necrosis, causing kidney fibrosis and cause progression of CKD. And till now, with the standard of care by using ACE or ARBs, you can see there was significant reduction in CKD and other endpoint, but even with the maximum dose of ACE or ARB, we still have a significant residual value, risk for our patient to progress and to have cardiovascular disease. And also, after the introduction of SGLT2 on the top of the ACE or ARBs, we still have significant residual risk. So this is where our new novel treatment comes in place to help with this residual risk. So as we said, for the hemodynamic driver, we use the ACE or ARBs, thiazide-like diuretics, control the blood pressure, use SGLT2, and for the metabolic part, we use SGLT2, GLP-1, anti-diabetic, and control the sugar. But till recently, there was no no treatment to address the inflammation and fibrosis. And this is where it's very important, because you can see inflammation and fibrosis can cause damage to the kidney, to the vascular system, and to the heart, causing higher morbidity and mortality. And this is all because of the mineral receptor pathway overactivation, which increase gene expression of the NADPH oxidide, pro-inflammatory cytokinase, and pro-fibrotic mediator. So this is where the new medication come to place by blocking this MR over activation, helping to reduce the inflammation and fibrosis, and hopefully helping our patient for better survival and less morbidities. So this is where comes Finerenon, which is a novel selective non-steroidal MRA, which blocks the MRA overactivation. And by doing this, our patient with CKD and type 2 diabetes, they have lower risk of CKD progression and cardiovascular event or mortality. And this is very important to differentiate Finerenon as a selective non-steroidal from the other available one, which is steroidal MRAs, like spironolactone, because of the structure, which is more bulky, high potency, very selective to the MRA receptors, which differentiated from the other in a way how it works, what the side effects, and you can see in the table here, basically with the new molecular, there is a significant effect on inflammation and fibrosis, much more than the other one, and also with less side effects, including any electrolyte disturbance. Even we get hyperkalemia, and we'll talk about it, but it's manageable and much lower than what we get with spironolactone. The effect on the blood pressure is modest comparing with the other, and this is all very important to keep in mind, because the efficacy of the patient, the way it works, and the side effects is different. So in the development of Finerenon, of course, there was a lot of like a program regarding phase 2, comparing it to placebo, to spironolactone, and Finerenon in diabetic patient with CHF, with CKD, and this is all showed that it works, and it's safe, and it's dose dependent. And after that, they had the phase 3 clinical trials. We'll go through quickly. So we have two complementary trials, one called Fidelio, diabetic kidney disease, and the Figaro, which is also on diabetic kidney disease. So you can see it's complementary in a way where with Fidelio, the primary endpoint was related to renal, and the Figaro was cardiovascular protection, and the secondary the opposite way. And of course, there was also another endpoints like all-cause mortality, all-cause hospitalization, change in albuminuria, and also other composite. And that's making it really unique in a way, because we will talk about what we call fidelity also meta-analysis, where it's unique because we have two similar trials, same design, giving us much higher number to look at the efficacy and the safety and to get better conclusion. So it's basic total, the two study about 13,000. Each one is a good number, more than any other trials for CKD in diabetes. And you can see the difference with the Fidelio. You can see on the graph, it covers really advanced CKD, most of the patient in stage 3 with moderate to severely increased albuminuria, while the Figaro trial, it extended the coverage to a much earlier stage with lower stage. So with both of them, it really covers the whole spectrum of CKD. So the design, as usual, it's just to compare Finerenon in 10 milligram and 20 to placebo. The study was up to 2.6-year follow-up, and we'll talk about the result and the endpoints result. So as we see here with the Fidelio trial, it was advanced CKD, and you can see 81% of the patient it's in the stage 3 and severely increased albuminuria. There was some exclusion like heart HFrEF class 2 to 4 and uncontrolled hypertension. So baseline characteristic as a summary, the CKD was, as we said, advanced. The mean GFR was 44 with median urine albumin creatinine ratio of 850. Most of the patients were on maximum tolerable dose of ACE or ARBs. The adherence was very high, 92%, and the side effects was manageable, and there was very low discontinuation rate. So looking at the primary outcome, which is kidney-specific composite, time to kidney failure sustained more than 40% decrease in GFR from baseline, or renal death. You can see that there was significant reduction by 18% with significant p-value and number to treat for 3 years, 29 patients. So this is really significant result. And also, if we look at the reduction in the urine albumin creatinine ratio, it was significant reduction by 31%, and you can see the curve separated at 4 months. And as we mentioned, albuminuria is early a marker of fibrosis and damage. So it's good to intervene as early as possible. For secondary cardiovascular outcome, time to cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure, again, it was a positive result and reduction by 14%, p-value 0.03, number to treat for 3 years, 42 patients. So with Fidelio, we had positive primary and secondary results. And with the efficacy, if we look at the safety and side effects, there was no no difference in the group between Finerenon and placebo. So, and as we said, lower discontinuation rate. And also, if you look in particular for the gynecomastia, because of the selectivity of phenoferrin, it's very low comparing with, as we said, the steroidal one. And if we look at the effect on the blood pressure and hemoglobin A1C, there was no effect on the hemoglobin A1C. For blood pressure, there was a slight reduction, maximum 2.7 reduction. So it was really not that significant. And again, because of the selectivity as the potency of the medication. And regarding hypercalcemia, which is predictable, just because how the medication works, there was increase in the potassium, but again, it was manageable and not that high. And the maximum mean difference around 4 months, it was increased by 0.23 millimole per liter. And as the SGLT2 and ACE and ARBs, it's also we can see acute reduction initially in the GFR, but very minimum, maximum 3 reduction in GFR initially, but the effect over the rest of the study was beneficial by reducing the deterioration of the CKD. So going back to, again, the hyperkalemia, because this is one of the issue most of the physician will ask about, the difference was, of course, higher in the treatment group, but it wasn't significant statistically. And it didn't lead to permanent discontinuation or fatal or death or any other significant one. And the way usually they started the medication, which we will do in practice also, depending on the potassium level and the GFR at the beginning. So if the potassium less than 4.8 and the GFR above 60, they start 20 milligram daily. If the GFR 25 to 60, start with 10 milligram. And the recommendation to repeat the potassium after 4 weeks. And if the patient still potassium less than 4.8 to increase the dose to 20. If the patient go above 5.5, then we have to stop the medication and restart again when the potassium less than 5, with always the lower dose, and check the potassium more frequently. So with the Fidelio DKD summary, we can see that we have a new medication, a new treatment, which is beneficial in the way of kidney and cardiovascular outcome on the top of the ACE or ARBs, which was treated, and those patients were really well controlled from the diabetes, hypertension perspective. And again, because it's addressing a key driver, which is inflammation and fibrosis, and the side effects was really manageable and no higher discontinuation rate. For the Figaro, I'm skipping because of the time, but also it was positive for the primary endpoint and the secondary. And now because we have the same design of the medication, the same endpoint, secondary and primary, basically it was pre-specified for meta-analysis looking at almost 13,000 patients. And you can see also the summary of both of the study. We can see 14% reduction in the risk of cardiovascular morbidity and mortality with significant statistical p-value. And also for the renal endpoint, which is CKD production, there was 23% reduction, again with significant p-value. And according to the label of the FDA label, which was updated, now it's indicated for CKD stage 1 to 4 of type 2 diabetes with CKD in the purpose of reduction of sustained decline in GFR, of preventing or delaying end-stage renal disease, cardiovascular death, non-fatal MI, and hospitalization for heart failure. In the European label, still the recommendation till now, stage 3 and 4 with albuminuria, and I think here in UAE most likely will be updated soon. So again, another question comes in clinical practice, what about SGLT2 in those studies? So at that time, when the study was done, the SGLT2 and GLP-1 was still underutilized. Until now, it's underutilized. But in the study, there was about 7% of the patient on SGLT2, and regardless if the patient was on SGLT2 or not, we got a reduction in albuminuria, as you can see, almost the same, 32%, 37%. And if we look at the other cardiovascular and kidney benefit, it was also positive in the two group, either irrespective of the SGLT2 use. And according to the guideline now, it's really recommended by name as a level A. This is ADA 2022 in the section of CKD, where it's recommended to be added for patients at increased risk for cardiovascular event or CKD progression or unable to use of SGLT2. It used to be with unable, but now it's only or. So they open more option to use a new treatment. And again, in June, it was updated again in the cardiovascular section by, again, level A recommendation to use it to prevent cardiovascular mortality and morbidity. So I will finish with just like a practical case, which I think we see it on every single day in our practice. So this patient, 66-year-old, diagnosed with CKD and type 2 diabetes, duration 4 years. His CKD detected at the time of type 2 diabetes diagnosis, which is very common, where the patient can come with already type 2 with complication. Hemoglobin A1C 5.5, so it's above 7%, but it's not that bad. Office blood pressure 138 over 80. Again, it's controlled in a way. Patient is overweight. If you look at the renal parameters, his estimated GFR is 42. His urine albumin creatinine ratio 410 milligram per gram. His serum potassium 4.4. Patient is already on statin, and his LDL according to the goal, and he's already on maximum tolerated dose of ACE or ARBs and standard diabetic care. So if we look at this patient renal function, again, we can see that his urine albumin to creatinine ratio more than 300. His GFR is low. So, and he's already on maximum tolerated dose of ACE or ARB. So similar to the Fidelio trial. So can we do something extra for this patient? Because as we said, by looking at the maximum dose of ACE of ARBs and even using SGLT2, there was still significant residual risk. So this patient is typical patient where he's candidate to be treated with Finerenon, the new medication. And you can see, if we look at this patient, as usual in our diabetic patient, the albuminuria getting worse slowly, the decline in GFR is going worse slowly. And if you look at taking both, he's already in stage 3B with severely increased albuminuria, putting him at very high risk of cardiovascular and progression of renal disease. So by keeping doing just ACE and ARBs, we can see that he's already deteriorating, and we have to really intervene. So this patient is candidate for the new therapy. His potassium is less than 4.4, and his creatinine clearance, his GFR is less than 60, so the recommended dose, as in the study, 10 milligram. Repeat potassium after 1 month, 4 weeks, and if the potassium is still low, can up titrate to 20 milligram. And if the patient develop hyperkalemia, which, as we said, is really not very high chance, then sometimes we have to stop and wait till it goes less than 5 and start again with 10 and monitor more frequently. So with this, I will finish. So again, we have a new treatment which really helping our type 2 diabetes patient with CKD by reducing progression of CKD, by reducing the cardiovascular event and death. We should really utilize it because, as we said, we need to really try to intervene early in the early stages before they go into stage 3, 4, then we have to send them to nephrologists. This is our job as internists, as family practitioner, to screen and maximize the ACE or ARBs and maximize the other treatment in the way of SGLT2 or the new medication Finerenon. Thank you.